Thank you so much, Dr. Schiff and Vineet, and to all of our speakers. We've heard a lot about different ways mobile technology is being used to reach the Medicaid population, and I think they all have some common themes of a focus on improving health outcomes, reducing costs, and also increasing the productivity of the healthcare workforce. And we are now going to turn into our Q&A system. I'm going to ask our operator, Steve, to come back to explain how you can ask a question over the phone if you're joining us by phone. And if you're just joining us on the web, you can continue to post your questions in the Q&A box on your screen.
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
Great, thank you. I'll ask a web question while we wait and remind our speakers that they can take their phones off of mute. A couple first questions going back to Erhardt's presentation. We had a few questions coming in about how you're leveraging your mobile technology to track the hours for the personal care assistants, and also how you address any regulatory and legal challenges related to the use of the technology and the notion of no cost to the member.
Let me do the hours piece first. So really the hours that the personal care assistants are using, so there's two things. One is we help set the hours through our own assessment. So we sort of go through a very detailed assessment. We understand what the member needs, and then so we sort of set the hours there. And then through this pilot, we're now able to verify the actual tasks that are done. We can tell how many feet away from the front door that a PCA checks in and how many feet away from the front door they check out, how quickly they got to the front door if they checked in sort of 400 feet away, et cetera, et cetera. So we can get some really good data to sort of verify that they were there, what they were doing, et cetera. So it's a whole new layer of visibility into what's going on. The second thing with regard to the legal aspects, I mean, obviously, we've been very clear with understanding what's clinical, what's not clinical, where sort of the guidelines are between the questions that can be asked one way or the other, and have obviously had our lawyers sort of review everything in grave detail. I don't know, Jerry, would you add anything?
Yeah, and we follow our internal processes to make sure that, no PHI information is going outside a unit. So we have one feed. We feed our information directly to Beata, and they're the only ones that see that information. And we've made sure that they have the security necessary to meet our demands to secure that information.
And obviously we may have made it look easy when we went through the slide, but as you can tell, or the person that asked the question knows, it's a little bit more complicated than what we showed.
Great. We also had a question, if you could just explain a little bit more about the personal care assistant and who you define as a personal care assistant, just to clarify for the audience.
Yeah, no, that's a good question, and they are called sort of different things in different states. So this would be somebody that goes into the home that does I'll give you my non-clinical speak. They don't really touch the member. Maybe they help with basic activities of daily living. They help with doing chore, maybe some bathing, but they don't do the highly skilled wound care. They're not clinical people. Basically just somebody that helps them to live in the home more independently. Is that fair, Jerry?
Yep, that is fair. So they wouldn't be administering any medications. It's not a skilled need that they're there to meet. They're just there to meet the activities of daily living. They'll do shopping. They'll do cleaning. They'll do some cooking for the member if they're not really able to cook for themselves. As Erhardt said, they'll do the bathing, the dressing. That's a personal care assistant.
And you'll typically, within Medicaid, the aged, blind, disabled Medicaid beneficiaries, as well as the long-term care Medicaid beneficiaries, you'll see this personal care concept or provider set used very often. So it's definitely something that's out there in a pretty big way.
And especially within the MLTSS program, the PCA workers, they're key to our ability to keep these members independent and in their home rather than having to transition them to a nursing facility. These positions are really what keeps the member out in the community healthy, making sure that they're independent as can be within their own homes, or supporting the caregivers.
Great, thank you. Operator, do we have any questions on the phone?
Again, if you would like to ask a question, press star, then the number 1 on your telephone keypad.
Great. I'll keep going with the web questions and just jump in if there's any coming in over the phone. We had a question, and I think probably for any of the speakers, what are some of the ways you found useful in addressing the social determinants of health, like food security and public safety? I think food specifically was mentioned in both the presentations, and Dr. Berwick, feel free to jump in from your perspective as well.
This is Erhardt. I guess I'll make a quick comment. I think the social determinants are probably the very first thing that we actually look at in most situations. As we all know, if somebody is wondering where they're going to get their next meal, they're going to be less worried about getting some type of a preventative test with their primary care physician. And so we educate our staff. We've got tons of community partnerships where we are able to really build and understand how we overcome and address the social determinants first. And this is not a commercial, but I will say on our website, horizonnjhealth.com, we have some outstanding stories about members that were homeless or members that had other issues that needed social help before we could address their medical issues, and we see it over and over and over and over again.
This is Don Berwick. I'll build on that. I mean, I think one of the important perceptions here, and I'd love to know what Jeff and Vineet think, is not to see mobile technologies as a freestanding, separate, disconnected, and highly effective intervention, absent its embedding in a larger concept of the nature of care itself. This question is asking about connection to food security and public safety. Think, for example, of Rebecca Oney's breakthrough in developing health leads, linking health care to social supports, very directly with very great services. Think about how mobile technologies and that reconceptualization interact. So I personally, as excited as I am about mobile technologies, and I couldn't be more excited, I'm even more so when I think about them as a brick in a larger building, which is the reconceptualization of care around production of health and empowerment of patients and meeting them where they are. Without that, we're asking for magic. But with it, we really can have tremendous change.
This is Vineet. Sorry, go ahead.
Oh, Vineet, I'll just stick in a comment in real quick. I agree completely with Don that I think the real opportunity here, and where we went to recruit provider organizations for this proof of concept with CareMessage, was first to our accountable care organizations, because these are people who are already working on integrating and looking for better results. And I think that, as Don said, and I couldn't agree more, this has to be lined up with the providers who are providing the care. What this does, though, is it gives a tool for what we think of as traditional clinical providers to integrate, as Erhardt said, with other organizations outside in a way that gives providers an opportunity to work together in a more meaningful way. And then I think what I think is really unique about this is the opportunity to get that feedback in a regular and ongoing and very quick loop, so the intervention can meet the needs of the recipients much, much faster.
Exactly, and the only thing that I would add to that is including resources, including information that is contextually relevant in the actual information that's sent to a patient, whether it's disseminated in the case of Horizon by a care manager, or in the case of what we're doing, sent as a text message. For example, when we work with local organizations in San Francisco or in Texas, we work with these organizations to really understand if a patient has a concern about getting access to healthy food, what are some local Meals on Wheels services that are available to make sure that this individual has the ability and the resources that they need to get to that resource, to get access to that information. In other cases, we have leveraged the power of connecting these individual patients and members to transportation services. For instance, if they're not able to make it to their appointment because of a lack of transportation, how can you make that information available, accessible, and then ultimately actionable, so that an individual who is not able to access transportation can just very simply by a basic text message indicate that they need transportation services, and how can that text message or that information be made available to the person on the other side and then take action. Really connecting the two, but then making it contextually relevant based upon the local circumstances, the geographies, et cetera.
Great, thank you all. As a follow-up question, someone has asked if you could talk about any of the barriers that you see to this important integration with community services, either with integrating with mobile or more broadly as we've been discussing.
This is Jeff. I'll start. I think one of the challenges that came up on some of the online questions I think is really relevant, and that's there is a barrier we have to work through overcoming around consent because of HIPAA and other privacy issues, and really have to figure out how to get consent up front for these. That's one thing. I think then the other things are really around how the clinics work this into their workflow, and I think some of the work that Vineet and his team have done around that can help reduce those barriers, but it still will require some resource and some reallocation of resources at the clinic system level to be effective.
This is Don. Part of this relates to teamwork. The concept, in my view, the concept that there are payers and then there are caregivers, and they're never the world shall meet, won't work here. We need imaginative payers able to work hand in glove with care delivery designers and clinicians like you're hearing on the phone today to view payment as a mechanism for changing care, not passively but actively. When I was administrator of Medicare and Medicaid, I will tell you it was difficult. We could see the frontier of possibility, but within the current regulatory, statutory, and sub-regulatory environment, it was difficult to find the daylight to say, oh, we really can help accelerate this development. That's mandatory, both on the commercial and the government side, in my view. I think there's progress in some of CMS's latest steps, especially with respect to the advanced ACOs, is starting to break some new ground on making this kind of innovation not just possible, but really smart. And I really hope that process continues.
Great, thank you. A few questions I'm going to try to combine together. If you all could talk a little about either successes or examples or how you're doing this in terms of using this technology and working with the blind, aged, and disabled population who, may not be as inclined to use text messaging, as well as, engagement among non-English speakers or, limited English proficient population, and sort of any special considerations or efforts that you're doing among those populations.
Sure, I think I can get started. This is Vineet. A couple things. The first one is, for maybe even stepping back, accessibility is the cornerstone of what we do. We understand that health information in particular, isn't very accessible, particularly to the patient populations that we're serving. So a couple things that we've done. The first is implementing voice communication in addition to text as another form of communication, enabling individuals that are blind or individuals that are illiterate, being able to have them be able to access that information via a voice message in addition to a text message, and enabling similar interactions via a voice channel. The second thing is optimizing for individuals that are non-English speakers, which tends to be a significant portion of the population that we're serving. So particularly Spanish-speaking individuals, every single message that we write is written in English and Spanish independently, so that there's a process by which we're not only translating the meaning of the information that we're translating, but we're also contextualizing that information and making that accessible to the population that we're trying to serve. So it's not a direct translation. It's essentially contextualizing the information as much as possible. And then most recently, we've enabled the use of CareMessage in about 30 additional languages beyond English and Spanish, so we can reach a wider base of the population that we're trying to serve.
This is Erhardt. Just a couple of comments to add. So first of all, we've got the scale and the size to be able to do this. I realize not everybody does this, but we're very purposely hire from the communities that we serve. We very much understand the demographic that we're serving and seek to hire native speakers and be able to pair them with the appropriate people. It's worked quite well. I think we have something like 13 languages spoken internally or something like that. But then the other thing, contracts always require having language lines and having all of your materials written in multiple languages. We certainly have that. But I'll tell you something that winds up getting used, and this has been in other jobs that I've had as well, is Google Translate. And it works quite well in situations where you don't have a native speaker, which is clearly the preference. But people wind up using that quite often. So.
Great, thank you. A few other questions came in also about how you use technology with adolescents and sort of overcoming the barriers of working with minors. I don't know if Vineet, maybe are you working with have you worked within that issue with them?
Sure. Yeah, absolutely. Actually, our first partner ever was the Lucille Packard Children's Hospital in Palo Alto, California, and we're specifically working with a mobile health van that's addressing adolescent health and some of those issues. I think from our perspective, what's really exciting is that obviously the use of mobile technology in this demographic is extremely high, particularly the use of smartphones, even within Medicaid and uninsured demographics is very high, and close to 80 to 90% smartphone penetration. But what's been very surprising and something that I think is indicative of the fact that we make a lot of assumptions about the populations that we're trying to serve, but when we actually dig in and actually look at the data, it's very different. Is that the perception and the receptivity to health information and receiving and engaging with the healthcare provider using mobile devices is very high. And it's something that's reflective of the fact that many individuals and patients in our healthcare system feel I think that there's a sense of feeling isolated and feeling removed from the healthcare system and feeling like there's not a lot of accountability and there's not a lot of care, particularly outside of the four walls of the clinic or the hospital. And so to the extent that we can make that available to as many individuals as possible, whether it's through a care manager that comes into their home and actually helps them take care of meals and provides them with the support that they need, or whether it's through a text message or a combination of the two, it's something that we see reflected in the elderly population. It's something that we see reflected in the middle-aged individuals, but certainly something that we see reflected in adolescents, particularly around use cases that are relevant to them, whether it's obesity-related concerns, whether it's pediatric or adolescent asthma and the adherence to that, or whether it's sexually transmitted conditions, et cetera. Those are some of the things that we think and have experience with in terms of improving adolescent care.
Vineet and Jeff, what about elders, especially frail elders? Are these technologies useful to them?
In our experience, Don, one of the things that's been really interesting is that with the elderly population, obviously the use of mobile devices in this demographic is high. It is not obviously as high as individuals that are on the younger side, but it is still very high, and it's something that enables us to directly engage. I remember a couple of years ago, we had a patient that was 95 years old that enrolled in one of our COPD interventions. So we definitely do see that as being a possibility. But also, I think within that population, in addition to directly engaging the patient, we see an incredible opportunity in terms of empowering the caregiver, and essentially whether it's the daughter or the son or the granddaughter or a family friend or someone that's responsible for taking care of that individual, and really how do we empower that person to make sure that person has all the right information and resources, and that person feels empowered and in control when it comes to taking care of their mom or taking care of their dad. That's something that's really important, and that's where we see the applications of these types of technologies maybe a little bit more exaggerated than in terms of directly engaging the patient.
So, Don, just to add to Vineet real quick, we have an organization out here that does care mostly in assisted living and skilled nursing facilities, and they've developed a mobile platform that is a bridge, and they use it specifically to connect their providers who are actually in the group homes or the facilities on an intermittent basis with the caregivers in those facilities, and then with the family members as well. So it works well if it's 3 miles away or if it's across the country. And that's gotten it's a great communication tool designed really to make sure that everybody's in the same loop all the time. And to your point about changing the balance of power, it really gives the information directly to family members simultaneously.
Thank you all. We have about 5 minutes or so left, so a bunch of questions. We're going to try to keep going through some of them. Erhardt had mentioned sort of an incentive to the personal care assistant. We had a few questions come in about other uses of incentives to increase sort of adoption and engagement with mobile technology, and also specifically the CareMessage technology programs, especially given the high rate of churn among Medicaid members. Could you kind of talk to the difficulties of engaging participants and kind of being consistent through the programs?
Part of what I think was important, and again, if all providers are important, but personal care assistants specifically, most of the time don't get paid very much. And there's always an ask to figure out how we might get more money into that provider set. And so, quite frankly, this is being able to pay quality incentives covers off a couple of different things that we want. One is getting more money into this type of provider. And so engaging people and figuring out how they're able to make more money works out very well. The Medicaid churn that you're talking about is probably less so in the aged, blind, disabled, and the managed long-term services and supports. And these are the populations that typically are served by the personal care assistants. So probably not quite as big of a deal. During our test, what we really wanted to know was if we paid some money, would it be important? Would it get their attention? And would we be able to influence an outcome? That's what we were really looking for over that 6-month pilot, basically. And I think based on all the data that we're looking at, the answer is a resounding yes. And so we're going to tinker with that. Literally, we paid some money to get people to visit PCP. So we're going to tinker with that some more and see where else we can go. But that very first sort of theorem was proven in our eyes.
One thing that I just wanted to add on the topic of incentives, obviously there's a huge amount of value in incentives that are monetary in nature or have some sort of benefit, whether it's coupons, whether it's gift cards, whether it's direct incentives to a premium, et cetera. One of the things that we have experimented with in our programs, not very directly, but sort of at a sort of a deeper level, is really the incentive tied to accomplishment. And particularly in our programs, when we implement a diabetes program, for instance, with a patient, we often have messages that say, you have completed 2 weeks of the program. Congratulations. Now we're going to talk about, insulin management, or now we're going to talk about medication compliance. And then they complete that program, and that they get a congratulatory message. We're still doing a lot of research into this. We have a research team that's dedicated to actually collecting some of these insights and some of these learnings. But sort of intuitively, when we talk to our individuals and our users, and we have conversations with them, one of the things that they often talk about is the fact that it made them feel the sense of accomplishment, that they had completed something, and that sense of accomplishment translated to them really internalizing that information, really treating that information as something that they should be thinking about on a regular basis. So even though it's not a direct monetary or very specific tangible incentive, just the fact that there is this sense of accomplishment, the sense of completing something tangible, even though it's a 2-week text messaging program, is something that we're still continuing to do more research on, but it's something that we're thinking could be a very powerful incentive when it comes to getting members and patients to be able to continue to have sustained engagement with some sort of program or messaging capability.
The last quick thing I'll add is the PCA workers, the personal care assistants, they loved, so money aside, they love feeling like they were a part of the care team now when they have the ability to give this information and to drive quality and do this other stuff. We heard that over and over and over again. They were just excited to feel like they were part of the care team instead of coming into the house and just doing chores or bathing or dressing or something like that. We got that a resounding number of times.
Great. Thank you all. We are almost at 2:30, so I did want to allow our speakers sort of one last opportunity to make any closing remarks, and potentially perhaps you could share with us sort of one policy or payment reform or delivery system change that would really help improve or enhance the use of mobile technology either in your program or more broadly in the near future. And maybe we could start with Dr. Berwick.
Yeah, I would like to see more experiments with payment so that this stuff could take off much faster and with critical assessment. And as I've shared with Vineet in my own conversations with him, these programs need evaluation. The evaluations are underway now. I think they'll be very reassuring. I'll bet that 2 years from now we'll look at this as absolutely inevitable in the armamentarium of care.
Thank you. Erhardt?
The one thing I'd add to my earlier presentation is obviously the state of New Jersey has been a wonderful partner, and that's critical in being able to use technology and pilot different things and have a great program. The technology, mobile technology specifically, in the way we view this in the pilot that we talked more about, is allowing us to be more aligned and to drive payment innovation and essentially move money into what I think is an underserved area. And we wouldn't be able to do that. We wouldn't be able to pay for quality if we didn't have this technology. So it really is the cornerstone to moving this forward.
Thank you. Dr. Schiff?
Thanks for letting me participate. Just a couple of things really quick. I like it if the technology came more nimble with time.
Could you speak up a little bit? We're having a hard time hearing you.
I moved my microphone earlier.
Thank you.
It would be great if we could have this technology be more nimble over time so that we can have, for example, one of our providers at Hennepin County in Minneapolis, or one of our big county hospitals, looked at housing insecurity and found out how to identify folks who are housing insecure before they get to the point of being homeless. And so the idea and the ability to use this technology in a nimble way, I think, is something that really provides the opportunity for providers to experiment, to actually serve their patients better. And then I want to reemphasize what Erhardt said, which I think is really important, is financial incentives are really important at some levels, but they won't, we think that if we can get folks to have a sense of belonging and a sense of participation in the care processes as providers, they're going to be much more empowered and interested in using the technology.
Thank you. And Vineet?
Yeah, thank you so much once again for everyone that participated in the webinar and for asking these very thoughtful questions. There were a few questions I was looking through the list of the Q&A log that had concerned with PHI and the question of HIPAA and regulatory questions like that. And if anyone has any more questions about that, I'm happy to talk offline. You can submit a request to our website, caremessage.org. I'm happy to chat about that. But specifically from the perspective of policy, one of the things that I would like to see possible would be more direction and guidance from ONC and from sort of the regulatory bodies that oversee HIPAA and TCPA around the use of mobile-based technologies, including text messaging, but other forms of applications and technologies, so that there is not a lot of uncertainty and questions around some of these things, that there's very clear guidance on how and when and in what capacity these technologies can be utilized. So to the extent that that information and guidance can be made available so that we can usher in this new era that we've been talking about, I think would be very helpful, particularly to technology providers like CareMessage.
Thank you all so much for joining us today, both to our speakers and our many participants. And if you'd please take a moment to share any feedback on this event with us. There's a link on your screen, the SurveyMonkey link. We will be, the slides are on our website, and we will also be sharing a recording of the event within the next week or so. So thank you all again for joining us today.